Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
In one of our end of the year best of 2024 SMR, Society of Melanoma Research episodes. We're trying to be festive here. We realize how ridiculous this looks. James, let's do a quick fire. Do you have a favorite holiday song, Christmas carol?
Oh, no. So I hate all that stuff. In fact, if I tell you my favourite Christmas song, it's probably going to be like a massive downer. I'm not even sure I should do it.
It's like from How the Grinch Stole Christmas or something.
No, it's a Tom Waits song, actually.
Oh.
It's beautiful. It's absolutely beautiful. If you haven't listened to it, it's called Christmas Card from a Hooker in Minneapolis. So, that is a...
Well done.
That is a memorable title. You're not going to forget that. But so listen to it sometime.
Do you mean to tell me in the Marsden, in your clinic or at home, there's no holiday tunes in the background?
Yeah, but I just, you put the radio on and it's all that sort of stuff. But it's the same, 20, 30 songs maybe? No, sure. I'm too old, right? I'm just sort of bored. I mean, I don't mind the Pogues one, which gets played a lot as well, but that's almost been sort of spoiled now anyway, I think. But you should listen to that, but listen to it more than once, because it's really pretty actually. And actually, I'm going to make a really boring comment now as well. And I think actually, if you listen to it, it's actually got the proper themes of Christmas going on in it. That's all I'm going to say, because it's pretty heavy comment. Anyway, so.
Well done. Okay. Well, do you want to talk about what we thought was one of the best from SMR?
Yeah. Well, I mean, I think arguably the data that were presented there that were most interesting, certainly to me, and maybe you agree with this, with the data Alison Betoff-Warner presented. And that, of course, links to one of our podcasts, which we will say what it is in a minute, because I'm not sure off the top of my head. So anyway, this is a pilot trial of elusive cellular therapy in brain mets, and really about feasibility and safety. So first of all, I think I would highlight our interview with Alison, where we talked about this. We talked about cellular therapy. We talked about exercise as well. So that was great.
Episode 51. For those who want to go back and listen.
Yeah, so episode 51. So I guess we all kind of know the background for lifileucel and TILs, but the bottom line here is in terms of safety and brain metastases, there are some data, but I guess not loads. And it's kind of one of the things I think, it's a pretty significant clinical problem in melanoma, and B, certainly I always worry about patients with brain metastases. Any case, so just maybe to cut straight to the chase, it's a small number of patients, only 10 actually, and the bottom line there is that basically in terms of safety, I don't think there were really any concerns. It was consistent with what we know already about lifileucel and the chemo and the IL-2, and then if you look at the efficacy, and there's a sort of small waterfall plot here, we can clearly see that there is at least some evidence of efficacy. So I think, honestly, probably, what does one take away from this? The fact that you can do it. I think, I was going to say, in clinical practice, this is obviously going to be a big question moving forward, especially in the US, where you've got potential access to this. And I guess my one comment about this kind of data set is that I think it's always worthwhile, if you've got a patient in front of you in the clinic, you really need to look and see if they match the inclusion criteria. I don't think this is carte blanche for treating people with brain mets, is what I'm really saying here. I think it's a small data set. We need some more. Anyway, you were going to say.
Well, I have two things to say now that you said that. Like, please adjust that the pillowcase. At least has a sweet jingle on it. I think it's really challenging for us in the real world to try to find a trial or inclusion and exclusion criteria that encapsulates each individual patient that we see in clinic. As it turns out, we see loads of patients with poor kidney function. And guess what? Guess who are not included on clinical trials? As our friend Lex Eggermont says, clinical trial patients are Olympians. And then we're treating non-Olympians in clinic. So I think we do have to be careful that, you might see a patient in clinic where they don't exactly match inclusion, exclusion criteria trials. And that's just because we don't have an inexhaustible number of trials. But back to your point, I don't think you can look at this small abstract and say, okay, I can now treat patients. I think that's absolutely right. This was more of a feasibility. Can we do it? And the reason is John Hannon gave an ASCO educational session this year on TIL. And I was able to go through his slides, and he makes a really nice point in there. You have to be eligible for all parts of the TIL process. So you have to be a surgical candidate. You have to be able to undergo the surgery, which may include general anesthesia. You have to be able to undergo the chemo. So you have to be fit enough with bone marrow and all those things. The TIL infusion, which we know has minimal side effects, but then also the high-dose IL-2 portion, which is cardiorespiratory fitness. And if you are not fit for all of those, you're not a candidate. So if you're only fit for the surgery and the cell infusion, but not the lymphodepletion, guess what? Not a TIL candidate. If you're a candidate for the surgery, the lymphodepletion, and the TIL, but you have some contraindication to the high-dose IL-2, not a TIL candidate. And guess what one of the contraindications to high-dose IL-2 is? Brain mets, untreated brain mets. So that's why this trial, I think, was so important, and why it was really lovely to see this work done very carefully under careful control to make sure that it's safe. But it's not yet the trial to tell us how effective it is. It just tells us when done well, it can be safe. And of course, I think you and I know this, but in the lifileucel trial, patients with untreated brain metastases were excluded. So that kind of goes without saying as well. They were excluded, symptomatic or untreated. So a great abstract number one.
I was going to say something else as well, though, actually.
Go on.
No, which you just reminded me about. So actually in our journal club this week, we saw the lung cancer data for lifileucel, right?
Yeah.
And it makes the point that you just made really graphically, because obviously people with lung cancer, a lot of them are going to have COPD, a lot of them are going to have cardiac dysfunction, and you look at how lifileucel pans out in lung cancer, and it really confirms that message that you just made. And I think the other thing that made me think a little bit is the point about the inclusion exclusion for the lifileucel, kind of regular lifileucel trial. Yeah, this isn't our clinic population, because actually our clinic population, we both know, and everyone knows, at least half of those people are going to have uncontrolled brain mets, actually. So there's some really nice points in there. So yeah.
Good. Okay, so another one of the abstracts that we liked from the SMR meeting was the KeyMaker. I like all the fidgeting that you're doing. So we know this is the umbrella study for Merck, has loads of sub-studies in there. And one of the sub-studies that was presented at SMR, substudy 02D, presented by Paolo Ascierto, who is lovely to see him mobile and traveling and on his feet, literally, these days, back on his feet. So this was Lenva plus quavonlimab co-formulated with pembrolizumab, or lenvatinib plus pembrolizumab, also for melanoma brain mets. So Lenva, we've had an episode in the past on the LEAP studies. Maybe I can tell you what episode that was, 39, where we talked about 004 and 003, the phase 2 and the phase 3 study, lenvatinib plus pembro. So multi-tyrosine kinase inhibitor with some VEGF inhibition in there. But the quavonlimab, the co-formulated with Pembro, is part of one of the arms here, and that is Merck's CTLA-4, anti-CTLA-4 compound. So they essentially have a fixed dose CTLA-4 PD-1 plus Lenva versus Lenva Pembro alone. So this study looked at these combinations in PD-1, PD-L1 treatment naive and treatment exposed patients. Essentially, 15 patients received the lenvatinib, quavonlimab, Pembro treatment, 15 in the treatment naive or the PD-1 naive cohort, 33 received that combination that had seen PD-1 or PD-L1, and then Lenva Pembro alone, whether they were prior exposed or not to PD-1, was 7 patients. It's a small study, but basically it's there for people to go through toxicity of this combination. The real question is, does this work? Does the CTLA-4 PD-1 co-formulation seem to have activity? Global objective response rate, 27% in the naive population, 18% in the exposed. And that mirrors the intracranial response of 27% and 15% PD-1 naive and exposed, and really limited activity with Lenva Pembro as we saw in the LEAP trials. So not great activity for this CTLA-4 PD-1 plus TKI, whether you had prior PD-1 or not. And they essentially come to that same conclusion: limited activity, inconclusive in the brain is what they're saying because of a limited sample size. I don't know. I don't see much happening with this combination. I'm not sure why my eye's watering here. Do you make anything with this KeyMaker?
No, I agree. I mean, nothing's really jumping out, I don't think. I mean, a very reasonable thing to do, but, a little bit difficult to interpret the data. But with all these things, we're always hoping for something to jump out and say, yeah, but I don't think it has, actually.
And it's a pity because we know Nivo-Ipi does have activity in the brain. It's a kind of a pity not to see a little bit more activity here. And then with the addition of lenvatinib, not much happening. So I'm not sure what we're going to see in this space moving forward. Okay.
Yeah.
Next abstract.
Next one is ematics, I think. So this is IMA 203, which is targeting PRAME in PD-1 refractory melanoma. PRAME's pretty highly expressed. I guess we know that cutaneous and uveal melanoma and other tumor types. And so this is HLA restricted. That's another thing to note. Patients get leukapheresis, and then this, I think they call it an engine actually, is created and then given back to the patients. And then they get some lymphodepletion and actually low dose IL-2 after it's given back. So reasonably decent numbers, I think, of patients. The melanoma, they call it the melanoma efficacy population, 28, so half and half roughly cutaneous and uveal melanoma. Quite a lot of high LDH at baseline, about 60%. They just say greater than upper limit of normal. Tolerability, I think, is sort of as expected, a bit of CRS. 4% grade 3 ICANS, no deaths. I mean, I thought the efficacy, if you look at the waterfall plot, didn't look bad at all. I mean, certainly the response rate's pretty high, 50, 60%. Some cutaneous, some uveal. I guess that's encouraging as well. And I suppose my only other comment really would be that the median duration of response is about 12 months. So I think that's okay, but it's not what you would be seeing for checkpoint inhibitors, certainly not in the first line situation. So I think some efficacy and quite encouraging. What do you think?
Can I ask you a question? Duration of response. Should that only be calculated in the responders? Because if you calculate it in all, aren't you basically just talking about PFS?
Yeah, well, yeah, as I understand it.
Yeah, okay. I'm just curious because their duration of response slide in their presentation is on a slide that graphs everybody. So I'm just curious if they calculated it. I presume they calculated it on just the responders, the 4.2 to 25.5, but I don't know.
Yeah, I hope so. Otherwise, like you say, it's PFS effectively, isn't it?
Yeah.
Uh,
And by the way, they should be fairly similar because the response rate was right about 50%. So duration of response and PFS, it wouldn't surprise me if they land similarly, but I'm just curious on that. My take is, I like the shrinkage here. I like the 88% of shrinkage. When you look at this waterfall plot, there's just very few patients who didn't get some benefit from the infusion. And that's even in these more challenging uveal melanomas, as we know, maybe even something happening in mucosal, but this study was not enriched for that population. So I think it's great. It doesn't tell us, of course, what the TIL in the last study told us is about how does this work in the brain, because patients with brain mets, I'm sure, were not included here. But anyway, it's nice to see this signal. And I think you and I both know this is moving on to essentially a registrational phase 3 now. So it will be interesting to see.
yeah, great. Next one.
Okay.
Now
KeyVibe?
is KeyVibe,
Okay.
like
So
our Vibe episode.
say that again.
I said like our Vibe episode.
Oh, like our voicing interesting bits. Yeah, yeah. So KeyVibe, I think we had already seen the press release on this study before the presentation. KeyVibe is adjuvant pembrolizumab versus pembro co-formulated with vibostolimab. Vibostolimab is an anti-TIGIT. I guess the bottom line is this adjuvant trial was basically stopped early. The believe the independent monitoring committee stopped it early because they didn't see an RFS. Basically, RFS met the futility criteria at the interim. So they didn't think that even if they enrolled to full amount, that there would be any chance that the co-formulated arm would improve RFS. In fact, the 6-month RFS was 80.3% versus 85.4%. Doesn't even matter that we don't know which arm is which arm in those numbers because there's too similar. So that study was discontinued, and patients who were on the Vibo Pembro arm essentially were offered to get Pembro monotherapy if they wanted to continue. Doesn't look like we're going to see any future work from this. I guess it's worth noting there was also a higher adverse event rate, which led to some of the consideration to discontinue this, 15.9% versus 6.9% grade 3 to 5. So adjuvant TIGIT plus PD-1 is not going to be a thing in melanoma. That's the short answer.
Yeah, I guess that's fair, isn't it? So we've seen.
Is there a longer conversation here?
No, just to say that it'd be Nevo for adjuvant, kind of no, at least based on checkmate 915, and now we see TIGIT, and so then the question still stands for anti-PD-1 plus LAG-3. So that's going to be something for the future, I guess. All right.
In the next maybe 1 year, we're hearing. So
can you hear them outside? I suspect they're already drinking.
I like that for you.
I'm sorry?
I like that for you.
You like it for me?
I mean, I just like that it's your Friday evening and you're going to get to go out with a bang. I still have 10 hours to go.
All right. So our last one is the MERLIN 001 trial. So this is a gene expression and clinico-pathologic test to try and help with decisions about sentinel node biopsy, basically. So good number of patients in this trial. I think it was about 2,000 altogether. And really that what they're trying to do is ask the question is, does this help in decision making with patients when you're talking about doing sentinel node biopsies. And there's actually loads of data here, but just maybe to cut to the chase. It was able, the test, to identify patients with a less than 10% risk of sentinel node positivity, but not those with a less than 5% risk of sentinel node positivity. And worth saying again that this was done prospectively. So I guess the take home there, if this became available for clinical use and reimbursement, all that sort of stuff, is it might, I guess, help surgeons if they're having conversations with these patients who are around about that level of kind of risk. And I suppose with sentinel node biopsies, there's a load of different factors that might go into it already in terms of decision making, and it might be another factor that you could use. But I don't think it's going to be we're going to do this test and it's going to give us the answer. That's my gut feeling. But go on.
Yeah, I mean, as I go through these, it looks like their primary objective was do we have a test we can apply to somebody's primary tumor that can help us decide on who to forego sentinel lymph node? So who has a less than 5% risk? This makes me think of our episode and discussion with Mark Ferries, episode 54. He's really thoughtful about sentinel lymph node, and, for clinically stage 2 patients, he does still think the procedure is helpful. And so it's, for some reason, if you wanted more reassurance, can you forego it? This study was powered in a way to try to figure out if they could get a low risk signature that identified patients with a less than 5% risk. And it turns out the test couldn't do that. The test could identify patients with a 10% or lower, but not a 5% or lower. So then with a low risk patient, you still might want to go get that node. It might tell you the opposite as well, which is you've got a high risk GEP coming back on a primary tumor. These patients have like 3 times 20+% risk of positive sentinel lymph node. And then maybe then it's a no-brainer for the surgeons to go and do it. But I'm not sure that this test is necessarily going to help the surgeons identify who not to do sentinel lymph node on, just as additional data for them. And I think, as Mark said, it's 5% or more risk of sentinel lymph node positivity. It's essentially worth potentially, that information is powerful for so many reasons, for prognostication and then therapy. So, but I mean, super well done that they looked prospectively at these 2,000 cases. And of course, as we look at their characteristics, they looked across a variety of melanoma subtypes. So that's great. Cutaneous types. So
yes, nice work. Yeah, in a really important area as well.
Yeah.
So we're done. That's going to be quite long in the end, isn't it?
Yeah, I mean, it's best of. So we didn't really, we may not have gone deep on all of these, but maybe people can access the presentations and go for more if they're interested in more details. But thanks for that then, and have fun at your holiday party.
Yeah.
Please wear the hat. All right. Cheers. Have a good weekend.
Ooh.